Then our next speaker is Dr. Oriol Roca. He is a consultant in critical care at the University of Hebron, which is in Barcelona in Spain. And he will talk about the scale-up of respiratory support, meaning the different doses of oxygen that you can supply, including high-flow nasal oxygen.
Thank you very much, Dr. Jeffermans, for this kind introduction. My topic would be about the scale-up of respiratory supportive therapies. These are my topics of interest to disclose, and this is the summary of my talk. We will focus on COVID-19 associated respiratory failure, how to escalate the respiratory supportive therapies, and we will focus especially on the physiologic effects of high flow, and one very important topic, which is predicting the need for intubation. Well, we all aware about the fact that COVID-19 is hitting again, and the number of cases are progressively increasing in all European Union and UK and worldwide, and some of these cases would need at some point of their evolution to be admitted in the hospital and be placed on some kind of non-respiratory supportive therapies. We could define acute respiratory failure as the loss of the ability of the respiratory system to ventilate adequately or to provide sufficient oxygen to the blood and the systemic organs. And we can divide the type of respiratory failure in two main groups. The type 1 is characterized by ventilation perfusion mismatch that leads to low levels of oxygen, of PaO2. In response to these low levels of PaO2, the patient used to hyperventilate at the beginning at least, and then the PCO2 remains normal or even low. In COVID-19, in the early phase, it has been shown that there is also some degree of pulmonary vessels damage that is represented in this figure by the purple and blue zones that leads to the hypoxia that we can observe in these patients. Some of them will recover and some of them will progress and go to what we understand as ARDS. So what is the initial assessment that we should do in COVID-19 patients and in all patients with acute respiratory failure that come to the hospital? We should look at the symptoms that the patient refer. We have to look at the signs of respiratory failure that could let us to stratify the severity of the respiratory failure, and we should screen all patients that come to the hospital with SpO2 measurement in order to determine which level of oxygenation that they have in the blood. If the respiratory failure is mild, we could start the treatment using a low-flow nasal cannula that allows us to deliver up to 6 liters per minute, which means that we will arrive to a fraction of inspired oxygen up to 50%. Our target would be to achieve an SpO2 between 94 and 98 and respiratory rate below 30 breaths per minute. And we should closely look at the response of the patient, looking at these two parameters, as well as physical signs of the severity of respiratory failure. Oxygen levels, as I said, will be assessed by pulse oximetry in all patients. It's very important to screen the existence of silent or happy hypoxemia that has been explained in different papers, and I would say that our target of SpO2 would be between 94 and 98%. Of course, we have to consider that if you have some problems with hospital oxygen supply, you could decrease this target to 92, 96, and you will be also in the safe zone, taking into account that if the patient is deteriorating, you have to move faster and scale the therapy faster. And in the presence of chronic respiratory disease, this target should be even lower, between 88 and 92. If you cannot achieve these targets, you have to increase the respiratory supportive therapy and move to a simple face mask. This simple face mask will let you to provide up to 10 liters per minute and achieve a slightly higher FiO2, which is up to 60%. But some patients are more severe and it is not enough. In this case, you can use the reservoir mask that led you to increase the FiO2 delivered up to 90%. But as happened before, if you don't achieve these targets of SpO2 and respiratory rate, you need to increase even more the respiratory support delivered to the patient. And maybe one option would be the nasal high flow oxygen, which allows you to deliver up to 70 liters per minute and achieving an FiO2 of 100%. How this high flow works, or why you can achieve 100% of FiO2. This is the flow time curve of a patient with the inspiratory flow in the upper part and the expiratory flow in the lower part. And if you are using a nasal cannula delivering 4 liters per minute, it means that when the patient breathes, it takes these 4 liters per minute from the cannula and the rest up to 50 liters per minute, which is the maximum inspiratory flow that he is needing from the room air. So the resulting FiO2 that arrives to the alveoli is a mixture between these 4 liters per minute and the 46 liters per minute taken from the room. In contrast, when you are using a high flow delivered to 50 liters per minute, all the air that the patient breathes comes from the cannula, and therefore the delivered FiO2 is exactly the resulting FiO2 that arrives to the alveoli. But the high flow nasal cannula does not only has this effect. All the effects of nasal high flow are flow dependent. So the higher the flow, the higher the effect. It increases the FiO2 breathed by the patient, as we have seen, but it increases the airway pressure because you always find a respiratory resistance at the expiration due to the continuous administration of a very high flow of gas, which leads to an increase in expiratory lung volume and some degree of lung recruitment that has a positive effect also in the oxygenation, because you are always delivering a continuous high flow. All the upper airway is washed from the exhale air, and you decrease the dead space washout and improve CO2 clearance. And the only way to tolerate 50 liters per minute is to provide the air with the adequate humidity. It means that the air that is breathing the patient is totally conditioned, which means that is 37 degrees and 100% of relative humidity. All these effects have a very positive effect in work of breathing and respiratory effort and drive, improving the comfort perceived by the patient. But if we look to the vicious circle of lung injury that has been recently described, what is interesting of high flow is that interrupts this circle at different points. It improves gas exchange, it decreases respiratory drive, and it decreases esophageal pressure swings, decreasing the perpetuation of the lung injury promoted by the patient. However, the relative contribution of the mechanisms of each mechanism is unknown and may vary among patients. The response of the patients is highly heterogenic. But what is very important or differentiates high flow compared to the other non-invasive techniques is that it's extremely comfortable. We have to keep in mind that the higher the flows are more likely to be worse tolerated. However, we have to titrate the flow as the maximum tolerated flow, even though we do not achieve the maximum effect. Because if the patient does not tolerate the technique, he or she will remove the cannula and you will get no effect. So it's better to keep the patient comfortable at 40 liters per minute than try to go up at 60. Another important point is that the comfort perceived by the patient is completely dynamic, which means that at the beginning of the onset of the technique, maybe the patient only tolerates 40 liters per minute. But after some minutes of getting used to receive 40 liters per minute, he or she will tolerate even 60. So we can start and titrate constantly the flow according to the tolerance of the patient. We will keep the cannula on the place longer time and will make the technique more likely to success. Another option for this very severe patient is to use CPAP or NIV. CPAP provides a continuous level of pressure, usually between 8 and 14 centimeters of water, by using a snag-fitting mask through which pressure is applied. In type 1 acute respiratory failure, this pressure opens the lower airways and improves gas exchange. In contrast, NIV provides two levels of pressure: an expiratory pressure that is usually called as PEEP or EPAP, and inspiratory pressure that is usually called as pressure support or IPAP, depending on what we are referring and the type of ventilator that we are using. The pressure settings may vary depending on the patient's or underlying condition and may vary day to day. Of course, CPAP or NIV have some contraindications. It's not recommended to use in an agitated or uncooperative patient. When the patient has a reduced level of consciousness, the probability of success is much lower. You have the problem of fitting the interface, so you have to take into account all these contraindications before starting the technique. These are the different interfaces that you can use. There are others, but mainly I think that most of the patients would use these ones. On the left side, you have a cannula that is used for deliver high flows. In the middle, you have a nasobuccal mask for NIV or CPAP. And in the right side, you have a helmet interface, which has been shown to be potentially beneficial in ARDS patients. However, if you use NIV, you have to monitor the patient very carefully and especially monitor the exhale tidal volume, because the exhale tidal volume is a determinant, or higher exhale tidal volumes have been associated with higher probability of NIV failure or even mortality. So if you place a patient on NIV and your exhale tidal volume is above 9 or 10 mLs, even you decrease pressure support, it means that probably this patient will not succeed on NAB, and you have to escalate the therapy to the intubation. And it's quite reasonable if you think about the vicious circle of the lung injury. If you put NAB and you increase tidal volume that up to 9 or 10 mLs per predicted body weight, it means that you are increasing the pre-existing lung injury and you are not interrupting the vicious circle of lung injury, and you are perpetuating this. The less common type of respiratory failure in COVID-19 patients is type 2. If you have a type 2 that, remember, is characterized for hypercapnia and acidosis, respiratory acidosis, NAB would be your first option. And remember that you should decrease your target SpO2 up to 88 and 92%. Well, we have a lot of devices, and the obvious question is which one I should choose. There are not a lot. This is, I think, the only data that we have in COVID-19 patients comparing different non-supportive devices. And what we can conclude from the data presented by the authors is that the use of non-invasive supportive therapies is feasible, which was questioned at the beginning of the outbreak. They observed no difference in the 30-day adjusted mortality, which means that the election of the device in the middle of the pandemic was mainly based on the experience of the team and the availability of the device. But importantly, 11% of the healthcare workers were contaminated. And this arises another important question, which is the risk of healthcare workers' transmission who were exposed to aerosol-generating procedures. And the only data that we have comes from the SARS one. And in this meta-analysis, we could see that high flow was not associated with a higher risk of transmission of the disease, but NAB was associated a higher risk of transmission of the disease. But if your option is to intubate the patient, you will have even a higher risk. So I would not say that don't use NAB, because if you use NAB and you use PPE and you do it properly, even though you have some risk of transmission of the disease, the prognostic of the patient improves, and your risk is even higher if you intubate the patient. This is a very nice data about how long the smoke dispersion of different oxygen devices arrives by exhalation. And as you can see, high flow is not the worst one compared with conventional oxygen. But what I strongly recommend is that if you use high flow on a patient, you place a surgical mask above the cannula, because as you can see in the picture, when you use 40 liters per minute, the smoke dispersion is practically disappear using this surgical mask. Another important point that I would like to highlight is that these patients with non-invasive respiratory supportive therapies need a very close and strict monitoring. Look at these two X-rays with practically the same SpO2, FiO2 ratio, but if you look to the patient, they look very different. One was very monitored with EIT, esophageal pressure, intracranial pressure, everything. And the patient on high flow, which is the one on your right, is only monitored with an SpO2, respiratory rate, and non-invasive arterial tension. But he is also very sick and very severe. and you have to look at them if you don't want to go late in detection those patients who are going to fail on high flow. Because late intubation is clearly related with worse outcomes. It has been shown using high flow, and it has been also shown using NIV. And there are some variables that are associated with high flow failure, either respiratory variables or non-respiratory variables. But only one of them has been prospectively validated, which is the ROX index. ROX index is defined as the ratio between SpO2 and FiO2 and respiratory rate, and when we compare the diagnostic accuracy of the ROX index with the other two variables separately, the diagnostic accuracy of the ROX index was better than the other two variables separately. And what is even more important is that here I show you the patients that met ROX index criteria for intubation, but they did not meet traditional criteria for intubation because they had a respiratory rate below 35. So these patients at 2, 6, and 12 hours were not intubated. But the question is, what happened at the end with these patients? If we look at the final rates of intubation of these patients, they are around 90%. So there is a room for improvement if you use the ROX, at least to be aware of those patients who are more likely to fail. And our proposal for the use of ROX that can be easily measured at the bedside is this one. You can measure at 2, 6, at 12 hours after high flow onset, and then depending on the value that you get, you may be consider intubation, or maybe you should increase support and reevaluate the patient, and then measure again the ROX after 30 minutes and look at the delta ROX, or maybe you are in the safe zone and you only have to continue monitoring your patient. And importantly, the usefulness of ROX index has been also tested in COVID-19 patients, and the findings were pretty the same. But if you don't want to use the ROX index, what it has been shown in COVID-19 is that oxygenation is important, and patients who fail after 1 or 2 hours of high flow are more likely to fail. And respiratory rate is also important. And if you look to the thresholds that predict failure, they are around 25 or 30%. So even less that we have been used in other non-COVID-19 acute respiratory failure patients. Importantly, the thresholds of the ROX index that were found in this cohort of COVID-19 patients were pretty similar than the ones that we describe in non-COVID patients. And regarding the use of NIV, you can use the Hacker score. It can be also very easily calculated at the bedside. You only use to measure the heart rate, make an ABG to determine the pH and the PaO2, FiO2, the Glasgow Coma score, and measure the respiratory rate. And what they show is that if you have a higher Hacker score, you are more likely to fail on NIV from the beginning of the technique. In fact, they describe a cutoff point that it was useful along all the follow-up, which was a cutoff of 5, higher than 5. And when they look to the patient that have a Hacker score higher than 5 after 1 hour of NIV onset, they observe that those patients who were early intubated, that means before 12 hours of NIV onset, presented a lower mortality. So it means that we have to monitor closely the patient and decide which patients we are more likely to fail, and then in these patients scale up the therapy as early as you can. And you have to clearly predefine which intubation criteria are you going to use in order to detect as early as you can which patients are more likely to fail, or which patients present this criteria, to scale up the therapy as fast as you can. So, summarizing, the most important take-home message that I think that you should keep in mind is that type 1 acute respiratory failure is the most common presentation of COVID-19 patients who become severely ill. It is very important to early recognize the clinical deterioration using SpO2 and respiratory rate and the ROX index or Hacker score if you want, because you must not delay the escalation of respiratory supportive therapy. Otherwise, the outcome of the patient will worsen. Thank you very much for your attention, and I remain for your questions.
Thank you, Dr. Roca. Do you hear me?
Yeah.
Okay. So allow me to briefly summarize what you told us. You provided us with targets of oxygen therapy, which is a saturation of between 49 and 89%, and also a respiratory rate that should be below 30. You told us that there are two types of respiratory failure, and COVID-19 is usually hypoxemic, for which high flow oxygen is useful. And there's also hypercapnic failure, and for that you could use non-invasive ventilation. And then you showed us some types of non-invasive ventilation which are more or less a health hazard to the healthcare workers or not. And you also provided us with a prediction of failure and need for invasive intubation. And the most important of these were the level of hypoxemia and the respiratory rate again. So I think this is useful. We will talk about non-invasive ventilation in another session. So I would like to now have some basic questions for you regarding the high flow nasal oxygen. Are there any specific contraindications?
No, not a specific contraindication. I mean, if you have a upper airway obstruction, you have to move for intubation, let's say, because it's impossible for the air to arrive to alveoli. But in case that you don't have it, there is no specific contraindication for its use. However, there are some patients that do not tolerate the technique due to higher flows at the beginning or even higher temperatures. So you can play with the flow and the temperatures to make the technique comfortable for the patient, and then you can progressively increase the flow after the patient is comfortable.
Okay, so this was my next question. So high flow nasal oxygen is both, you have two determinants. One is the flow, which is expressed in liters per minute, and the other one is the FiO2, so the amount of oxygen that you give to the system. So if your patient is hypoxemic, how should you increase the support? Should you first increase the flow or first try to increase the FiO2?
As all the mechanisms that beneficial mechanisms of high flow are flow dependent, I would say that you have to give always the maximum tolerated flow and then titrate the FiO2 to get your target SpO2. Once the FiO2 is below 0.5, then let's say 0.5, 0.45, you can start decreasing the flow. It's the same parallelism that we could say with PEEP and FiO2. You increase PEEP to recruit the lung, and then you decrease once you have an FiO2 below a certain point.
And when can you switch from high flow nasal oxygen to just normal oxygen support?
There is no clear indication, but I would say that if you have 30 liters per minute or below with an FiO2 of below 0.5, I would try to move to conventional oxygen, at least to make some kind of conventional breathing trial, conventional oxygen breathing trial, let's say.
Okay. Would you recommend high-flow nasal oxygen following a patient who could be successfully detubated after invasive ventilation, and you are unsure whether the patient will remain stable, and you consider reintubation, or could you use high-flow nasal oxygen?
I would recommend immediately after extubation to prevent the post-extubation respiratory failure. If the patient has already a post-extubation respiratory failure, the probability of success decreases a lot. So I would suggest to place the patient immediately after extubation on high flow.
Okay. So can the high flow oxygen therapy, can it also be administered on the ward, or does it need to be on the ICU?
It can be administered on the ward, but and indeed is what we had to do during the pandemic, because we don't have enough ICU beds to meet everyone, and we had to start high flow in the wards. But all these patients need to be closely monitored in order to detect early failure.
Okay. Okay. Thank you very much for your clear explanations.
Thank you.